Hi, this is Advances in Hemodialysis Part 1. Hemodialysis. The number of patients requiring chronic hemodialysis is rapidly growing worldwide. Up till now, we have around 3 million dialysis patients and expected to increase this number by 2020 to reach 3.8 million dialysis patients. And hemodialysis both greatly reduce the quality of life and is associated with extremely high mortality rate, exceeding 50% of patients by cardiovascular death. Right now, looking for a better outcome of dialysis patients, we have to look for types and amount of uremic toxins removed by the current therapy. And we have to look for the deferred organ damage, and this removal of uremic toxins should be applied and looked for to postpone and defer the organ damage manifested by uremia. What is the current hemodialysis therapy limitations? The 5 points of the current limitations are: therapy depends only on filtration, on clearance of solids, and part only of the solids are removed. Nearly complete retention of protein-bound uremic toxins. The volume overload state and salt intoxication. Patients are frequently overloaded. Problems in inflammation and malnutrition. Inflammation per se can increase the toxicity of the uremic toxins and considered to be an amplifier of the uremic toxins. The non-physiological hemodialysis frequency, the intermittent hemodialysis, as well the short duration of hemodialysis are not physiologically to the body. Looking for more quality of life, looking at dialysis therapy that optimize patient care. 2 points are very important when dealing with dialysis patients: to control the fluid overload, as well to control the uremic toxins. So the recent advances in hemodialysis will be included, the current advances as well the future advances. The current advances: more permeable hemodialysis membranes are applied right now. More physiological therapy. Example, prolonged dialysis session, nocturnal hemodialysis, and more frequent hemodialysis or daily hemodialysis. More convection therapy also are needed to remove much more of the uremic toxins. And right now is online high efficient hemodiafiltration. What about the future? The future therapy will be on the bioartificial kidney and the implantable device, and both will be discussed later. Towards better dialysis, what are the current and the future? More looking for membranes of hemodialysis, more permeable to uremic toxins, convection therapy, more removal of the middle molecules. Towards better dialysis currently applied nowadays include better hemodialysis membranes permeability for more uremic toxins, including the middle molecules, higher convection treatment, removing the middle molecules, and high efficient online hemodiafiltration is currently in practice in many hemodialysis centers. Prolonged session to remove more uremic toxins and to decrease the rebound, giving the chance for the equilibrium between the blood and the cellular uremic toxins concentration. More frequent hemodialysis could be like daily hemodialysis or short sessions of daily hemodialysis to be more physiological. Adsorption, which is the only way to remove protein-bound uremic toxins. And in order to apply these advances, we have membranes with higher sieving coefficient, removing much more of the middle molecules, convection treatment, amplified clearance, high efficient hemodiafiltration, prolonged session, improve the compartmental removal, improve the rebound, more frequent and more physiological, and the adsorption, remove bigger molecules. Hemodialysis, the filtration therapy, depends on the clearance of the molecules, either by removal by filtration and the toxins appear in the dialysate, or removed by adsorption and the toxins are adsorbed on the hemodialysis membrane. Increase the filtration, meaning increase the flux, and also removal by adsorption through a higher transmembrane pressure during hemodiafiltration. Hemodialysis membranes is increasing both in fluxes and in volume. While early it was only low flux dialysis membrane, removing a limited uremic toxins molecular weight. Then the progress to high flux membranes, removing much more of the middle molecules. Then recently, the high performance membrane, which is superior than the high flux membrane in removing the middle molecules. The low flux membrane has only the diffusion clearance capacity, while high flux has diffusion and convection clearance. The high performance membrane has diffusion, convection, and accepted limited albumin leak. The current hemodialysis membrane has also increasing in the pore diameter and innovations in the dialysis membrane. Since early 1980, low flux, then progressed to high flux with minimal albumin leak. and starting from the 2000 high performance membrane allow less than 3 gram albumin leak. Better sieving coefficient from the low flux with a very limited molecular weight of uremic toxin that could be achieved in hemodialysis. With high flux membrane, we can achieve higher molecular weight in the middle molecule range to be removed. And this is the gap between the high flux membrane and the glomerular basement membrane sieving coefficient, as albumin leak is not a good sign that for hemodialysis we have to determine a smaller fraction of the albumin to be lost in the dialysate. This is the highest sieving could be achieved towards the renal sieving. The pore diameter that determine the molecular weight that can pass through the dialysis membrane. We have the high flux with narrow pore diameter and the high cut-off dialysis membrane with nearly double the pore diameter than in high flux, and both of them are away from the plasma filter. The high cut-off dialysis membrane can remove middle molecules and bigger molecules in the range of 40,000 Dalton, while high flux dialysis membrane still has some limitation in the molecular weight of around 20,000 Dalton, maybe higher in some membranes as well. This graph illustrates the electron microscopy of dialysis membrane in pore diameter, the difference in high flux and the high cut-off on the pore diameter, while in protein separation membrane and the plasma separation membrane, it's clearly obvious that pore diameter is extremely bigger than in both the high flux and the high cut-off membrane. So the high cut-off membrane is one step forward to remove much bigger molecules than the high flux membranes. Of course, the protein leak will be higher than in the high flux. What are the uremic toxins that should be removed? Then how to remove? These two questions should be answered to understand the current value of hemodialysis and what we are looking in the future. The uremic toxins that should be identified. Such a component should be chemically identified. The total body and the plasma levels should be higher in uremic than in non-uremic subjects. Higher concentrations should be related to specific uremic dysfunction and or symptoms that decrease or disappear when the concentration is reduced. And these molecules should be biologically active, confirming to clinical changes observed in conjunction with the uremic syndrome, should be proven in vivo, ex vivo, or in vitro studies. Both 4 points identify what is the uremic toxin. Then we have to think how to remove. The approach for hemodialysis therapy based on uremic toxin. Which type of hemodialysis therapy to choose and on what pace? Is it a short arm in randomized clinical trials that you follow? Low flux, high flux, hemodiafiltrations or others? Or in depth to understand the uremic toxins and how we can achieve the removal of such compounds? In order to reach this conclusion of low flux, high flux, or hemodiafiltration, we have to apply this scenario. Identify first the proposed toxins by the 4 points we discussed in the previous slide. Identification of the toxins by proteomics, protein analysis, or the metabolic activities of such compounds. Then measurements of such compounds concentration in uremics versus healthy subjects. Studies on the clinical correlation to the toxic effect on cardiovascular, for example, neuropathy, anemia. And if we apply these uremic toxins by the previous steps, then we have to think about the hemodialysis kinetics, how we can remove. Is it small to remove by low flux, or bigger to be removed by high flux, or hemodiafiltration, or we need other therapy? In proteomics analysis, higher concentration of middle molecules are found, which are extensive retention in uremia. The molecular weight of such compounds are retained in patients with chronic kidney disease and are hardly removed by regular hemodialysis. The difference in polypeptide between uremic and the normal plasma using high flux membrane ultrafiltrate showed that when using high flux dialysis membrane, the filtrate contained around 1,300 peptides, while using the filtrate in normal plasma around 500. So there is a lot of polypeptide retained in patients with uremia. Either it's correlated or not correlated to the clinical findings in patients with renal failure needs more extensive research and randomized control studies on that. Accordingly, higher pore diameter for both diffusion and convection are currently applied, removing much more of the middle molecules like beta-2 microglobin, still has a limited albumin loss. Looking for the molecular weight of the toxins like beta-2 microglobin, beta-2 microglobin is 3.8 nanometer in diameter, while albumin has 7.8 nanometer in diameter. So we need to refine the pore diameter in the hemodialysis membrane to be sharp to remove what is required from the uremic toxin to be removed and still preserve the essential proteins in the body like in albumin. In general, the requirements for an adequate dialysis needs 5 steps to be applied. Number 1 is a good arteriovenous fistula. The vascular access is important to improve the dialysis adequacy. Arteriovenous fistula and the fistula first program has limited complications than other vascular access, like arteriovenous graft or the vascular catheter. Then you have to choose a better dialysis membrane, more permeable for middle molecules, efficient surface area, and of good design, giving the patient the third point of the blood flow rate to achieve the adequacy of the hemodialysis session. You can assess by KT over V or the urea reduction ratio. Then number 4 and 5 are prolonged dialysis session, the duration of the session, as well the frequency. By these 5 steps, you can achieve an adequate dialysis. Also, in the advances in hemodialysis for the previous years, dialysis in special occasions beyond uremia. Examples: patients with multiple myeloma, patients with acute kidney injury from rhabdomyolysis, and as well in sepsis. Efficient removal of immunoglobulin free light chains by hemodialysis for multiple myeloma using high flux, superflux, or high performance dialysis membrane and the high cut-off dialysis membranes. There is a reduction of the free light chain, kappa and lambda, with both 3 types of dialysis membrane. High cut-off dialysis membrane is the best to remove much more of the free light chain, but has a limited use for both the cost and its albumin leak. On the other hand, online hemodiafiltration achieves high serum free light chain removal than the regular high flux hemodialysis in multiple myeloma patients. The kappa and lambda free light chains with molecular weight of 22.5 kilodalton and 45 kilodalton in hemodialysis versus hemodiafiltration versus high efficient hemodiafiltration, meaning that substitution fluid around 22 liters per session, and the difference as well is noted for both the kappa and the lambda. Although the difference in molecular weight between both of them approaching 45 kilodalton and 22.5 kilodalton, but could be achieved by online hemodiafiltration. Also recently, patients presented by acute kidney injury in acute rhabdomyolysis, myoglobin molecules is difficult to be removed because its molecular weight is big, but this is not the only limitation. The limitation is it's as well spherical in shape with some electrical charges, but could be removed by high performance membranes and better removed by high cut-off membranes with higher sieving coefficient, better to be with continuous therapy like CVVH, continuous veno-venous hemofiltration, but randomized controlled trials is still required. In some studies with different hemodialysis therapy in acute kidney injury as severe rhabdomyolysis, the removal rate of myoglobin using high flux hemodialysis therapy in the sled technique or in the conventional hemodialysis compared to the high cut-off dialysis membrane, which is higher due to poor diameter related removal. So high cut-off dialysis membrane are superior in removing the myoglobin molecules in patients with rhabdomyolysis and acute kidney injury. The limitation is using high cut-off hemodiafiltrations membrane in rhabdomyolysis, we have extensive albumin loss. Still we have a rebound in serum myoglobin following the dialysis therapy, but we can achieve a reduction ratio of about 80%. So the limitation of such a therapy in critically ill patients with rhabdomyolysis is albumin loss and the rebound. The rebound could be managed by continuous therapy, and albumin usually needs substitution. In sepsis, long studies had been done to treat patients with acute kidney injury with permeable high flux dialysis membrane. The basis of that is to remove, even temporarily, the cytokines produced from sepsis. Some clinical evidence on using high cut-off treatment on cytokines removal with reduction in serum inflammatory and anti-inflammatory cytokines is common in all identified studies. Significant reduction in the total amount of circulating interleukin-6. Reduction in interleukin-4, 6, 10, and 12 in patients with multiple organ dysfunction due to sepsis and the following cardiac arrest. Usually, the molecular weight of cytokine determines the kind of therapy and more efficiently to be removed continuously as the production rate is high. So the preferred therapy in such cases is the continuous renal replacement therapy. Hemodialysis membrane with a high cut-off removal in sepsis complicated by AKI depends on the molecular weight of the cytokine. If it's small, like 9 kilodalton, the removal rate is high. If it's bigger, the removal rate is slower and lower in amount. But here, the cumulative albumin loss is around 7 grams. Dialysis therapy from convection to adsorption techniques. Protein adsorption to the dialysis membrane surface is another phenomenon which can have a significant impact on solid removal. The removal here is not from the clearance of the solid by passing through the pores. Instead, as these molecules are big, could be adsorbed on the membrane. With increasing size of middle-sized proteins and the other compounds, relatively more clearance is achieved by membrane adsorption compared with loss into the dialysate. Some hemodialysis membranes has higher adsorptive capacity than others. So adsorption is the adhesion of such macromolecules and proteins to the dialysis membrane surface, but without penetration. And it is primarily depends upon the internal pore structure and the hydrophobicity of the dialysis membrane, which can attract the protein-bound toxins into the internal thickness of the hemodialysis membrane. A high adsorptive membrane may have also negative consequences. That's because it can reduce the diffusive and convective capacities of the membrane by blocking the pores. A moderate level of protein adsorption combined with the ability to bind protein-bound uremic toxins appear to be recommended features in the membrane. However, membranes with high adsorptive capacity may be completely blocked by plasma protein very early during hemodialysis therapy, a phenomenon that is called protein fouling of the dialysis membrane. Hemodialysis with higher adsorptive capacity like PMMA membrane, is different from polysulfone. The polysulfone membrane are usually asymmetric, which means that on the membrane thickness of the 30 micron to 40 micron, and on only one layer, about 1 micron, is responsible for the sieving separation process, while the remaining part of the membrane have structure function only. On the other hand, PMMA membrane is symmetric membrane in which the whole thickness is involved in the separation process that allow more middle molecule to be absorbed on the wall. By protein analysis of two different dialysis membranes, the polysulfone and PMMA membrane, we can find that the absorptive amount of total proteins is high with PMMA membrane, and this pattern of electrophoresis is mainly for larger molecular weight protein, which usually cannot be removed by permeation or by filtration. So removal here by adsorption into the hemodialysis membrane. Still, such membranes could have a protein fouling which is very high to continue as a dialysis membrane for diffusion and convection.